Today we are going to talk about the understanding and how to diagnose, how to recognize heart sounds, and we are going to do it different way than what's written in the books. So let's start. Traditionally you have been told to recognize S1, S2, you have to keep a stethoscope here and your fingers on the carotid. Why? What are you trying to see? So you are trying to see the carotid upstroke, which comes with ventricular systole, right? And when the ventricles contract, the mitral valve and tricuspid valve, they close, shut, and that produces first heart sound, right? So the first heart sound is produced by closure of mitral as well as tricuspid valve, and that's called lub. In traditional words, you call it lub. But the point is that this is a wrong way of diagnosing which one of the two sounds is the first heart sound. I'll tell you the reason why it is a wrong way. Number one is an auscultatory sign. You're putting a stethoscope here and trying to listen to lub-dub, 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 right? And you're trying to find out your mind as to which one is the first heart sound by palpating on carotid. So one is an auscultatory sign, other is a palpatory sign, and to coordinate the two is not easy. That's one. Number two, go back to your physiology. When the ventricle contracts, right at the contraction, right in the beginning, the atrioventricular valves close, mitral and tricuspid. So that happens right in the beginning. And when will you feel the carotid upstroke? When the ventricle has already contracted and pushed the blood into the aorta. So that will happen a shade later than the closure of the first heart sound, right? So for these two reasons, it's not a good idea to try to diagnose first heart sound by putting a stethoscope here and putting your hand on the carotid, for these two reasons. So I'll tell you how to do it. What was my teachers told me, how to diagnose or how to know which one is the first and which one is the second. So this is the reason why I am talking to you about how to correctly know which one is the first, which one is the second heart sound. And this talk is for beginners. It's not for people who are doing MD. This is for beginners, right? And I hope you'll be benefited by it the most. Before you put your stethoscope on the heart, you are supposed to do an palpatory examination, right? Palpation comes before auscultation. But many times, because you are in a hurry in the examination or when you are examining patient, you are in a hurry, you don't have time for all that palpation, this, that. You want to put your stethoscope over the heart first and then go back to physical examination or palpation and other thing, which is extremely wrong. I'll tell you the reason why. So before you put your stethoscope over the heart, please make up your mind whether your patient has left ventricular enlargement, right ventricular enlargement, bilateral enlargement, or no enlargement. And please do it in your examination as well. Make up your mind. Write it down on your sheet. Whether your patient has LV enlargement, RV enlargement, both or none. Because in the final analysis, it is going to help. How will it help? I'll tell you. Suppose there is mitral stenosis, and all of you know that mitral stenosis means this becomes too tight. This hole becomes too tight, almost 1/3 of its normal aperture. So, blood takes more time from left atrium to come to the left ventricle, and even after a full diastole, less blood comes to the left ventricle. So left ventricle has lesser blood to pump, which it pumps out when it does contract. So now, if you have made up your mind about LV enlargement and you have written on your copy sheet that my patient has LV enlargement, and then you hear a murmur of mitral stenosis, and you are trying to diagnose mitral stenosis, it's a mismatch. Mitral stenosis does not have left ventricular enlargement. So if you had diagnosed left ventricular enlargement and you are trying to diagnose now mitral stenosis alone, well, either MS is wrong, this diagnosis is wrong, or mitral stenosis has something else too. It has mitral regurg, it has aortic regurg, because rheumatic heart disease sometimes comes in more than one valve involved. अगर आप पहले सुन लेंगे मरमर, तो आपका माइंड टेंटेड हो जाएगा, पार्शल हो जाएगा, और फिर आप लेफ्ट वेंट्रिकुलर एनलार्जमेंट नहीं डायग्नोज कर पाएंगे. सो इसीलिए बिफोर यू पुट योर स्टेथोस्कोप ओवर द हार्ट फॉर auscultation, please make up your mind whether you have LV enlargement, RV enlargement, both or none, and write it down. Because ultimately, when you try to diagnose which murmur or which lesion the patient has, you must kind of tally it with your LV and RV findings. Is it clear? But the point is, how will you clinically diagnose LV enlargement and RV enlargement? So this is a kind of a PA view of the heart, and this is the left ventricle, which makes the apex of the heart. In the front is the right ventricle, and this is the right atrium. Where is the left atrium? Behind. Right behind the right ventricle. Right ventricle is almost below your sternum. Okay? So now, if you want to diagnose LV enlargement, what is the clinical sign of LV enlargement? Apex beat will be down and out. Apex beat is here. This is made by LV, left ventricle, most of the time, unless the right ventricle is hugely enlarged and the heart is rotated, then RV can make the apex beat, but usually most of the time it's LV which is making the apex beat, right? So apex beat will be down and out. Very simple. The normal place of apex beat is left fifth intercostal space within the mid-clavicular line. Some of you are very used to talking about the centimeters. That apex beat is 12.5 centimeters from the mid-sternal line. I am not interested, because 12.5 centimeters from the mid-clavicular line in a thin petite girl will mean different than in a sumo wrestler. In a sumo wrestler, it may be within the mid-clavicular line, but in a small, thin girl, it may be outside the mid-clavicular line. So I'm not interested how many centimeters it is from the mid-clavicular line. I'm more interested, is it within the mid-clavicular line of that person or not? Understood? What exactly is the apex beat? What is the apex beat? Can you tell me what is the apex beat? Okay, so the apex beat is the most downward and outward definitely felt pulsation of the heart. That's how you define apex beat. The most downward and outwardly felt, definitely felt pulsation of the heart. And it is usually made by the left ventricle, and when the left ventricle gets enlarged, the apex beat goes down and out. So very simple. Before you have put the stethoscope on the heart and auscultated the heart, you have written down on your copy LV dilated, LV normal, just by palpating apex beat. Suppose patient thick chest wall and you are not able to palpate the apex beat well. What are you going to do then? Just what are you going to do? Huh? I can't hear you. Turn the left and palpate. That's one way of doing it. Yes or no? So can we turn the patient and palpate the apex beat? If the apex beat is not palpable in the supine position, let me see how many says yes. Try to express yourself. Yes, raise your hands. A little more, little more, little more, little more. And what about the rest? How will you do it? So never ever turn the patient to left to palpate the apex beat, because you have shifted the apex beat. The heart is not exactly tied down in ropes at one place. When you turn the patient to the left side, you have shifted the apex beat to the left side, and you may misdiagnose that the apex beat is down and out. So never ever do that. You can make the patient sit and bend forward. That's all right. That doesn't shift. Okay? So this is about the clinical diagnosis of left ventricular enlargement. Now let's come to the right ventricular enlargement. So how will you clinically judge right ventricular enlargement, other than the facts that when the right ventricle is enlarged and not functioning well, there will be raised jugular venous pressure, there will be hepatomegaly, there will be pedal edema and all those things. But beyond that, on palpation, on the chest, what will you get which will suggest that there is a right ventricular enlargement? You have, say what? Where is the right ventricle? I told you the right ventricle is right in the front. If it enlarges, what is it going to do? Touch the sternum. Even press the sternum. So what sign will you get? You will get a left parasternal heave. LPH. Left parasternal heave. How will you clinically check? You will put the flat of your hand this on the left side parasternal, and this will actually come up and down. Not this much, but yes, a little bit. Right? So this is called LPH, left parasternal heave, which signifies right ventricular enlargement. So it's not difficult to diagnose left ventricular enlargement, down and out apex beat. never turn the patient to the left side to palpate the apex beat. And right ventricular enlargement with presence of parasternal heave. The classical prototype of a parasternal heave you will see in mitral stenosis. Why? Because it's right here. This valve is tight. Atrium, left atrium has got dilated because it cannot push all the blood into the right ventricle, and this left atrial is enlarged and the pressure goes up. This pressure is transmitted through the lungs to the right ventricle, and the right ventricle also enlarges. And where are the two? Right ventricle in the front, left atrium at the back, both have enlarged. So you will get a classical parasternal heave. And it is actually impossible to diagnose a significant mitral stenosis without a left parasternal heave, because both are supposed to enlarge, the left atrium as well as the right ventricle. And sometimes both are enlarged. You have the parasternal heave as well as the left ventricular down and out apex beat. So you write both are enlarged. And sometimes none is enlarged. You don't get a parasternal heave. Apex beat is at the right place. You say none is enlarged. And then you proceed to put your stethoscope over the heart to recognize first and second heart sound, not by the classical way of palpating the carotid, but by the way I'm going to tell you. It's clear so far? So we have two heart sounds, S1, S2. Remember the basics. Number one, they are high-pitched sounds. What does that mean? Which part of your stethoscope will be able to pick them up better? The diaphragm or the bell? The diaphragm. Good. So high-pitched sounds are better picked up by the diaphragm. So use the diaphragm. And if you are not able to hear them properly, you can now turn the patient, because you are now not palpating for the apex beat. You are trying to hear now. And in hearing, it doesn't matter whether you have turned the patient or not. You can turn the patient to the left lateral decubitus position and ask the patient to take breath out, because once he takes inspiration, he inhales a lot of air, and the lung can overlap a little bit of heart, and heart sounds can be difficult to hear. That's what happens in emphysema, where the lungs are enlarged and almost start covering the heart, right? So how will you best hear the S1, S2? By maybe turning the patient to the left, asking the patient to take a breath out so that the heart is in direct contact with your stethoscope. And the first heart sounds are produced by closure of mitral and tricuspid valve. The mitral valve is best heard here at the apex. Tricuspid valve is somewhere here. Here, I'm talking about hearing. So it's left parasternal fourth intercostal space is the best place for tricuspid valve sounds. So if you want to concentrate, there are two components of S1. One mitral, other is tricuspid. M1, T1 makes S1, right? So you want to hear the M1 better, you can put your stethoscope, the diaphragm of your stethoscope over mitral valve. But you want to hear the tricuspid valve better, come back on the left fourth intercostal space. Usually, both these sounds come together. So there is usually no split. It's a one sound. But if for some odd reason tricuspid valve closes later, then there could be a split, M1, M1, because M1, T1, the tricuspid valve will close later, and mitral valve will close a little earlier, so there will be a split. Usually there is no split. What will delay the tricuspid valve to close is one classical example is atrial septal defect. That, there is a hole here and the right atrium is receiving blood from both superior and inferior vena cava as well as the left atrium. So it receives huge amount of blood, and that huge amount of blood takes some time to cross the normal tricuspid valve to go into the ventricle, and so the tricuspid valve is slightly delayed in ASD. Same thing happens in right bundle branch plaque because the impulse reaches late to the right side, and that's so usually there is no splitting of the first heart sound, but there could be a splitting in this situation. The S2 is caused by closure of the aortic and pulmonary valve. And when will they close? At the start of diastole. As soon as the ventricular relaxation started, the body doesn't want the blood to flow back from aorta and pulmonary region back into the ventricles, so it closes these valves. So S2 is caused by A2 and P2, right? A2 and P2. And usually A2 occurs earlier than P2. So, and usually there is a small split in an inspiration. Why in inspiration? Why is P2 a little late in inspiration? Because when you take an inspiration, you create a negative pressure and more blood is sucked into the right atrium through the inferior and superior vena cava by the negative pressure. And this more blood reaches the right ventricle. And so right ventricle takes more time to throw it off. So it closes little later in inspiration. So in inspiration, having a splitting of the second heart sound is normal. In inspiration, they go wider. In expiration, they come closer, right? And you will hear A2 here in the right second intercostal space is the aortic area. Left second intercostal space is the pulmonary area. And which ventricle is thicker, right or left? Left ventricle is thicker. How much? 3 times. So left ventricle is 3 times thicker than right ventricle. And so when the left ventricle dilates or contracts, it does it with much more force. And that's the reason A2, aortic second sound, is louder than the pulmonary second sound. But you will always say, we will put stethoscope here and we will put stethoscope here, and usually A2 is louder than P2. If P2 is louder than A2, what is it? Pulmonary hypertension. So it's not difficult to diagnose things. And I am making this very simple. And so I am excluding certain if and buts. But for your initial MBBS stage, you have to remove if and buts to make it very simple for you to understand. So normally A2 is louder than P2. If P2 has become louder than A2, it's pulmonary hypertension. There are other signs of pulmonary hypertension. We'll come later. Once you have understood this, now we will come to how to recognize these sounds. We theoretically call them lub-dub, but how will you come to know whether the first start sound is lub or dub? I mean, they don't come with a sound like lub-dub, lub-dub, not that, right? So, I do not want you to palpate carotid. I want you to put your stethoscope on the heart, on the apex of the heart, and close your eyes and keep listening. So if you close your eyes and put the stethoscope over the heart, you will hear something like lub-dub, 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 lub-dub. Why is lub the first heart sound and dub the second heart sound? Why? Very simple physiological thing. Which is longer, diastole or systole? Diastole. All of us know that. So now I know the first heart sound starts systole. The second heart sound starts diastole. So now you tell me which of the gap is longer. Listen to it again. Lub-dub, 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 lub-dub. Now between lub and dub there is hardly any gap, and then there is a long gap. So that's the reason lub is the first heart sound, dub is the second heart sound. Because after the second heart sound there is a long gap. Between the first and second there is a short gap. Lub-dub, 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 lub-dub. Could you understand? Right at the back. समझ आ रहा नहीं आ रहा बाप पीछे लोगों को? So आपको कैरोटिड पे हाथ रखने की जरूरत नहीं है. Just by listening to the pauses, you should be able to diagnose what is what. And it doesn't really matter even if there is tachycardia. Now in a tachycardia it will be lub-dub, 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 lub-dub. Now lub-dub is so fast, and then there is a slight gap. And then, so whether it is lub-dub, 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 this is almost like 70 beats per minute. And if you make it 140 per minute, lub-dub, 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 lub-dub is, they come closer. And it becomes difficult to understand everything, the dynamics, etc. in a tachycardia patient. But still you can understand that which is what. So I think today you are going to go back, put the stethoscope on your friend's heart and listen to your friend's heart. Close your eyes and just concentrate. And then you develop acumen. With practice, you can actually concentrate on each one of them. Like if there is lub-dub, then you are concentrating on only lub. Lub-dub, 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 lub-dub. Sometimes you are concentrating only on second, because when you are hearing it for the S2 in aortic and pulmonary area, you are only concentrating on second heart sound. You are not concentrating on the first heart sound. Like in aortic area, it's lub-dub, lub-dub, and in pulmonary area, lub-dub, lub-dub. The second heart sound is not that is not that loud as in the aortic area. Okay? So once we recognize this first and the second heart sound, right now I am omitting the splitting of sound, because we can actually have a 1 hour session on the types of splitting. the fixed splitting, the paradoxical splitting, and how to. I can only tell you one thing, that now I'm going to tell you about S3 and S4. And you always thought that you couldn't hear S3 and S4. But today, you will understand how to diagnose S3 and S4. So again, we come to the basics of S3 and S4. S3 and S4 are low-pitched sound. What does that mean? That means you should not hear it with try to hear it with your diaphragm, you should try to hear it with your belly. And S3 and S4 predominantly, if it is being produced in the left ventricle, you will hear it better with bell on the apex. And maybe turn the patient to the left side, left lateral decubitus position, so that the heart is almost in the left ventricle, is almost touching your stethoscope. It won't touch your stethoscope, but still it will come closer to your stethoscope. And if you are trying to hear a right ventricular third heart sound, you have to be near the tricuspid valve, because both ventricles can produce third and fourth heart sound. And I'll come to that, why are they produced and what are they. So, if we make a heartbeat like this is line, this is lub and this is dub, and this is lub and this is dub again, this is systole and this is diastole. So S3 sound is called S3 because it comes after S2, nearer to S2, right? Because it is nearer to S2, it is early in diastole. That's why we call it S3. And S4 is late in diastole. We call it S4. What happens in early diastole? You have to tell me. जब diastole होता है तो क्या होता है? Aortic pulmonary valve बंद हो जाते हैं, mitral tricuspid valve खुल जाते हैं, और ऊपर से means atrium से blood flow करने लगता है ventricle में. अब आप सोचिए कि patient has cardiac failure. The patient's ventricular muscles are not as strong as in a normal individual. So if suppose there is a 100 ml of blood in a ventricle, unfortunately it is only able to throw out 40 ml. 60 ml remains because the pump is not strong enough. There is a systolic failure. There are two kinds of failure, systolic and diastolic. Or we can say heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction. So systolic failure is heart failure with reduced ejection fraction. So if the patient has a heart failure with reduced ejection fraction or systolic failure, the patient's left ventricle was not able to pump the total blood it received. So when the diastole occurs, there is already blood there. Some amount of blood is already there. And on top of it, the blood comes from the top. And that makes a sound, which is known as S3, which is a low-pitched sound after second heart sound. This is a very simplistic explanation. If you go into the books, there will be 4 or 5 explanations for S3. That, the ventricle is dilated so much that when there is more blood comes, it goes and touches the touches the chest wall and so on. But I'm being slightly simplistic and trying to avoid confusion around. Because once you understand the simple things, then you will be able to build a castle over that. The foundation has to be strong. Okay, so that causes the third heart sound. This is the explanation. The third heart sound is normal when the patient is young. It is normally heard in people less than 40. Or it is heard when there is a hyperdynamic circulation. Which are the conditions of hyperdynamic circulation? Anemia, thyrotoxicosis, pregnancy, fever, AV fistula. So in these situations, like fever, anemia, thyrotoxicosis, pregnancy and AV fistula, it will happen. But if the patient is not below 40 and the patient does not have any one of these, the patient is suffering from a very serious systolic dysfunction of the heart, and it's a bad prognostic sign. It's not a good sign to have. So if you ever hear third heart sound, please exclude these things. And once you have excluded these things, you come to a conclusion that the patient is not good. The patient has a bad systolic failure. Maybe his ejection fraction is 20%, 25%, 30%, as against normal of 50 to 60. You understood the basics of S3? So we go to S4. And then I'll tell you how to recognize these sounds so that you are able to pick up when you see patients. S4, as is shown here, is late in the diastole. The diastole is about to finish. What is the event which occurs at that time? What is the main event which occurs at the end of diastole, before the diastole is about to finish? What happens? You should be very clear about the cardiac cycle, which you read in second year or first year maybe. क्या होता है? वेंट्रिकल में नहीं होता, कहीं और होता. Atrial contraction. So atrial contraction does not occur at the time of ventricular contraction. Atrium contraction occurs just before the diastole is about to finish. Why? Because now most of the blood has come from atrium to the ventricles because the valves are open and diastole has been there for some time. But the body wants to push whatever is remaining in atrium into the ventricle before the diastole stops. And so atrial contraction is the final event before the diastole stops. So ventricle में already blood है, काफी भर गया और atrium contract करते हैं. So whatever remaining blood is there is pushed out against a non-compliant heart, and then S3 happens. अगर तो heart compliant है, compliant का मतलब it dilates a little further, relaxes a little further, accommodates that blood easily. That's a normal heart. But if the patient has left ventricular hypertrophy because of either left hypertension or because of aortic stenosis or because of hypertrophic cardiomyopathy, then the thicker muscles is difficult to relax further. It's a relaxation failure. It's a diastolic failure. The systolic function is fine. The ejection fraction is all right. It is a heart failure with preserved ejection fraction, which occurs in almost 50% of the cardiac failure. The 50% of the cardiac failure is with reduced ejection fraction, 50% is with normal ejection fraction, diastolic failure. So when the atrium contracts and the ventricle is unable to dilate further, relax further, and accommodate that extra blood, a sound is created which is known as S4. And as I said, it will not be heard in normal individuals usually. They say if the patient is very old, sometimes you can hear it normally without any issue, because patients say at the age of 80, the patient's heart is not as compliant as at the young age. As against S3. S3 is maybe normal below 40. S4 could be normal above 70, 50, 75 sometimes. But S4 is usually pathological. And the causes of S4 I have already told you is mainly hypertrophy and ischemic heart disease. Ischemic heart disease again makes the heart less compliant. Diabetes could be one cause of diastolic failure. In about 50% heart failure of again diabetes, you will have a diastolic failure rather than a systolic failure. And you will have a S4, which is later in the diastole than S3. Now, how will you recognize it? So once you have mastered the art of recognition of S1 and S2, you will try to master the art of recognizing S3 and S4. And as my teacher taught me, I'm teaching you. He says, close your eyes, and whenever there is an extra sound, try to map it. So I'll make you listen to that sound. So there is one sound which is labdabba, 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 labdabba. This is one sound. There is an extra. If it would have been normal, it would have been labdab, labdab. Now it is labdabba, 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 labdabba. And this sound you are hearing only with your bell of the stethoscope better than your diaphragm. So this is an extra sound, third or fourth, you will have to decide. And there is another sound which is like blub-dub, 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 blub-dub. Normal was lub-dub, lub-dub, lub-dub. This one is blub-dub, 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 blub-dub. So first you will have to see, ये जो sound आपको extra सुन रही है, ये is it lub-dubba or is it blub-dub, blub-dub? Once you are sure which one of these your sound is, you will be able to recognize. Now tell me, lub-dubba, lub-dubba, is it third or fourth? Easy. Every one of you said third. Why? Because it comes very close to the second heart sound and easy to recognize. Similarly, blub-dub, blub-dub is a fourth heart sound because it's happening right before the first heart sound. At the end of diastole, the atrium contracts and that is not able to, right? And you know the significance of these sounds. Sometimes when they are splitting of first and second heart sound, usually first heart sound is usually not split. Second heart sound is normally split in inspiration. How will you differentiate? Try to listen with the diaphragm and bell. If that extra sound you are hearing, you hear better with bell, it's a third or a fourth heart sound. And if that sound is better heard with diaphragm, it's a split. Because the split are heart sound, which are high-pitched sound, which are better heard by the diaphragm. So I'm telling you very simple formulas. The formulas which I used when I was a student, which my teacher taught it like this. My teacher never told me, keep a hand over carotid and try to recognize. That's a bunkum. And every book still writes the same. Keep your finger here. And this is the reason why I'm recording it today, because I'm going to put it on YouTube for the beginners. This is not how you should do it. This is how you should do it. Right? So now The last part, we come to in another last 5-10 minutes left, we'll talk about murmurs and how to time the murmurs. So what exactly is a murmur? Murmur is a sound produced by turbulence of the blood. Normally the blood flows without turbulence. Turbulence can be created by 3 mechanisms. One, when there is increased blood flow, through normal valves. Second, forward flow through obstructed valve. Right now we are talking about valve. It could be produced in arteries also. Carotid bruit is a murmur. To and fro murmur in the femoral is a murmur. But right now we are not talking about that. And third, backward flow through an incompetent valve. These are the 3 ways turbulence is created. And when this turbulence is created, you hear a murmur. All of you know that there are grades of murmur. 1 is hardly audible. You will never be able to hear grade 1 murmur. And the grade 6 is the murmur can be heard from outside, in the sense that your stethoscope is not touching the heart, touching the chest, and even then you can hear the murmur. So that's a grade 6 murmur. So you could be anywhere between these grades. So 1 is the intensity of the murmur. Second is the site of murmur. Where exactly is the murmur? Is it in the mitral area? Is it in the tricuspid area? Is it in the aortic area? Is it in the pulmonary area? Best heard. Sometimes the murmurs are heard quite all around. Like aortic murmur could be heard almost all over. Sometimes, Third, where exactly is the radiation of the murmur? Like murmur is best heard here in the apex, and in the rest of the places is not very well heard, but if you keep going to the axilla, you can hear it to some extent in the axilla. So that is the radiation of the murmur. And what are the procedures which increase or decrease the murmur? That's how you... One thing I want to tell you is that intensity of the murmur does not decide the severity of the lesion. Please ingrain it into your mind. Ingrain it into your mind. ऐसा नहीं है कि murmur बहुत loud है तो आप डर जाओ. You say, oh my God, you've got a very bad valvular lesion. The murmur is so loud. It's not. To give you an example, Melody D. Roger, or Roger, whatever you call it. Roger was a scientist, and Melody means bimari. So Melody D. Rogers was invented by Roger in somewhere 1897 or something, long time back. That the smaller the ventricular septal defect, the louder the murmur. So when the defect is this pinpoint, the murmur is huge. So huge that probably you are able to hear it with your stethoscope off the chest. Is it of any consequence? No, nothing. Will you do something? No. You leave the patient as such. So don't be under the impression that a loudness of the murmur decides the severity of the lesion. No, never. Severity of the lesion are decided by all different things. We will tell you that when we'll tell you about mitral stenosis, aortic stenosis, etc., etc. Reverse example is a big ASD does not produce any murmur in the atrium. Why? Because there is hardly any difference between the pressures in the right atrium and the left atrium. There is a huge pressure difference between left ventricle and right ventricle. Left ventricle systolic pressure goes up to almost 120. And in the right ventricle, it doesn't go to 120, it just goes to 20, maybe 15. So that's the pressure difference. So if there is a hole in the ventricular septum, on one side of the hole is a huge pressure. On the other side, there is a less pressure. It's like Pichkari. The murmur produces huge. While in ASD, lot of blood is actually shifting from left to right, which it should not. But it doesn't produce any murmur there. So the severity of the lesion is not reflected in the severity of the loudness of the murmur. All diastolic murmurs and all systolic murmur more than grade 2 should be investigated. That's another law. So all diastolic murmurs must be investigated by echo Doppler. And similarly, all systolic murmur more than grade 2 should be investigated by echo Doppler. Right now, because we are lazy, we have less time to examine patient. I think whenever we are in doubt, we order a echo Doppler. It says, छोड़ो, ये भी मत सोचो कि ये systolic murmur है या diastolic murmur है, कैसी murmur है, कुछ सुनाई दे रहा? Okay, send it to the echo guy. We do that. Which doesn't make your brain sharper, it makes your brain dull. Then last bit of it, today's lecture is about how to recognize systolic and diastolic murmur. And again telling you the systolic murmur could be short, could be long, could be pan-systolic, could be mid-systolic. That's another matter. पहली चीज तो ये diagnosis होनी चाहिए कि is it systolic, is it diastolic, or is it both? Every murmur has its character, like all of us have our own character, unique character. And my guru used to tell me that, if you are hearing a diastolic murmur which is not harsh rumbling, then you should almost think that yes, it is dog barking all right, but it is not my dog which is barking, right? So almost that example he used to give, and that example is still with me. So we will just tell you today how to, once you know what is the first heart sound, what is the second heart sound, you know which is systole, which is diastole, and then you kind of plot the murmur in your mind as to where is it filling it. I will make you listen now 2 murmurs, and you will tell me whether they are systolic or diastolic. One goes like this: lapshi tap, lapshi tap, lapshi tap, lapshi tap. This is one murmur. The second murmur is drub dup, drub dup, drub dup, drub dup, drub dup, drub dup. पहली वाली कौन सी थी? सिस्टोलिक, डायस्टोलिक? कितने लोग कह रहे हैं सिस्टोलिक और कितने लोग कह रहे हैं डायस्टोलिक? गुड. सो डेफिनेटली बिकॉज इट फिल्ड द सिस्टली, लपशी ढप, लप ढप, उसके बाद एक लॉन्ग गैप है. सो इट इज विद इन, वेदर इट इज tachycardic also you will understand. Lapshi ढप, lapshi ढप, lapshi ढप, lapshi ढप, lapshi ढप, lapshi ढप. If it is not that fast, you will say lapshi ढप, lapshi ढप, lapshi ढप. So this is systolic murmur. Then the other one was a harsh, rumbling diastolic murmur of mitral stenosis, which is a prototypical murmur of mitral stenosis, which goes like drup dup, drup dup. It accentuates before the diastole finishes. Drup dup, drup dup, drup dup. Why does it accentuates? Because the atrium contracts and the valve is tight, and so the murmur becomes little louder before diastole, unless the patient has atrial fibrillation where the atrium is not contracting at all. Even then it becomes loud. I'll tell you the reason why, but that will be in your mitral stenosis class. So this is a classical diastolic murmur. So I think we are done with our time. Yes, it's exactly 1 hour, and I hope you kind of understood the basics of S1, S2, S3, S4, how to know whether it is S1, S2, how to know whether it is S3, S4, where to look for them, how to look for them. And remember always, before putting your stethoscope, please make up your mind whether it is LV dilatation, RV dilatation, both or none. Don't put stethoscope before that, because that will, that's a kind of a security mechanism. Once you make a final diagnosis, you kind of check it with your RV dilatation and LV dilation. Thank you very much.